Hello, welcome to Pathagonia. This is Jay. Today we are in for a treat. We are going to discuss the newest Carcinoids as of January 15, 2024, Respiratory Cytology. Before we begin, if you already haven't, check out Carcinoid's website. It's got great notes on all organ systems, reporting diagnoses and comments, a little about me section of Dr. Schaberg, as well as useful links, among other things. And on a tangent, but very important to me personally, today the Buffalo Bills beat the Pittsburgh Steelers in this super wild card weekend. So they're advancing and hopefully they make it to the Super Bowl. Okay, I got that off of my chest. Let's begin respiratory cytology, first with the WHO system. There are different diagnostic categories, including insufficient, inadequate, non-diagnostic, benign, atypical, suspicious for malignancy, and malignant. And there is a cited risk of malignancy based on the diagnostic category. A caveat that Dr. Schaberg gives is the cited risk of malignancies are very broad, so he has chosen to give simplified approximate numbers. Brief commentary is when you are a cytopathologist or when you are on site receiving lung tissue and you're going to diagnose what the tissue shows, remember to maximize tissue in your cell block and preserve this tissue for clinical testing. Oftentimes, lung tumors are diagnosed based on biopsy, and we can help the clinical team and the patient by preserving the tissue to send for ancillary testing such as your ALK, EGFR, ROS1, PD-L1, those targetable mutations to help the patient. So, insufficient, inadequate, non-diagnostic category. This is when you are on site and for quantitative or qualitative reasons, it doesn't explain that targeted lesion, that for instance, like 3 centimeter by 3 centimeter spiculated mass in the right lower lobe. And possible reasons, you might have low cellularity, necrosis, poor preparation, and remember, any atypia is not insufficient, inadequate, non-diagnostic. You can write rare atypical cell scene, for instance. Just to talk about semantics, insufficient and inadequate are used for cases where there's a lack of cellular material, while non-diagnostic is used in cases where there are benign findings that just don't explain that spiculated mass, for instance. A common scenario is when you have an FNA of a lung mass and you only see a benign bronchial epithelium, which we will talk about in the next slide. You can report as either non-diagnostic and say it doesn't explain the mass lesion on radiology, or benign with a caveat in your diagnosis comment that this may not be representative and that repeat biopsy may be necessary. When in doubt, as a pathologist, always think about that saying and always include correlation with clinical and imaging findings is required. Let's talk about cytohistology. Bronchoepithelial cells, or ciliated respiratory epithelium. It kind of looks like Beaker from the Muppets. You'll have this cilia and you'll have this terminal bar, as you can see here. And they'll have this basal round oval nuclei with even chromatin, and again, a lot of hair or cilia. I wish I had that much hair. Okay, on squamous cells, this often represents oral contamination, and it's identical to squamous cells at other sites, such as your pap smears. You'll have this abundant keratinizing cytoplasm. That being said, you can see squamous metaplasia with irritation and inflammation, for instance, a chronic smoker. Goblet cells, these can be intermixed with your bronchoepithelial cells, and you'll have mucin-filled cytoplasmic vacuoles, and it's commonly increased in chronic conditions like COPD and asthma and bronchiectasis. So before you diagnose mucinous neoplasm, could this just be goblet cells in the back of your head? Especially if there's no cytologic atypia or really large enlarged NC ratio or mitotic figures. Alveolar macrophages. So you want to see this in your bronchoalveolar lavage specimens. Why? Because that tells you that they've sampled in their lavage all the way to the bronchoalveolar unit. That is where alveolar macrophages exist. They don't exist in just the bronchus. So it tells you and tells the clinician that they sampled at the distal portion. Cytohistologically, you'll see abundant cytoplasm, often with granular debris and pigment. That pigment can be anthracotic, which is seen as black, or hemosiderin, which can be brown. You'll see vesicular nuclei with fine chromatin. And then you can have cartilage encasing the trachea, encasing the bronchus, and you can see extracellular and other bronchial tissue. You'll see extracellular thick material with chondrocytes in the lacunae if you look closer. And you can also see other bronchial tissue like smooth muscle, fibrous tissue, bronchial glands, and lymphocytes. Benign lesions, these are unequivocal benign findings, because if it weren't unequivocal, then you want to put atypical. Acute inflammation, this is inflammation dominated by neutrophils. You can have varying degrees of necrosis, degeneration. You may see bacteria and or fungus, and there can be other inflammatory cells, debris that may be present. Their differential includes your number one, infectious, such as your pneumonias, but also it could be due to aspiration, infarction, vasculitis, and unlikely to be a malignancy. If you see this at rapid on-site evaluation, send for cultures. Granulomatous inflammation, these are collections of epithelioid histiocytes and giant cells, and often mixed with lymphocytes, neutrophils, eosinophils, and you may or may not have necrosis, which will affect your differentials. For example, your necrotizing granulomatous inflammation, you want to think about tuberculosis mycobacterium. Histiocytes have syncytial epithelioid cytoplasm. They're elongated, often indented like a boomerang or barefoot nuclei, and it looks like a school of fish swirling around. And here's your H&E correlate of your cytohistology of a granuloma. Differentials include infection, especially TB and fungus. Get your AFB, get your GMS. Autoimmune, including sarcoidosis and diagnosis of exclusion. Vasculitis, hypersensitivity pneumonitis, drug reaction, and aspiration. And other inflammation like lymphocytes. If you see a lot of lymphocytes, think about lymphocytic interstitial pneumonia, hypersensitivity pneumonitis, sarcoidosis, Bessett's disease, lymphoma, organizing pneumonia. If you see a lot of EOs, if you see Charcot-Leyden crystals, you want to think about eosinophilic pneumonia, asthma, allergic bronchopulmonary aspergillosis, Church-Strauss disease, parasitic infections, and histiocytes. If you see a lot of hemosiderin-laden macrophages or histiocytes, think about prior alveolar hemorrhagic events. Lipid-laden macrophages with your oil red O being positive, think about aspiration, lipoid pneumonia, EVALI, which I had to look up. It's e-cigarette, vaping-associated lung injury, and amiodarone toxicity, and organizing pneumonia. Just a side note, BALs or bronchoalveolar lavages from pediatric patients are often sent for oil red O staining to look for lipids because it can be indicative of aspiration if it's positive like this, but this isn't actually all that specific or sensitive, and there's this PubMed article that Dr. Schaber cites. You can see extracellular material, this kind of granular grungy debris. If you see this, you want to think about pneumocystis urevetsii. It infects immunocompromised hosts, classically patients with AIDS or patients with HIV who've just not been treated at all. You'll see that, again, your frothy, proteinaceous cast. And on GMS, you can see these crushed ping pong balls with a central dot, and it will be PAS negative. Alveolar proteinosis. This is abnormal accumulation of surfactant protein in alveoli. It can be congenital, primary, or secondary, and you have this dense amorphous globules in a dirty, frothy background that will be PAS positive, oil red O as well, and negative for GMS. And also, not only is bronchoscopy diagnostic, but it's also therapeutic for those with alveolar proteinosis. Kirschmann spirals. These are coils of inspissated mucus. That's a hard word to say. It's non-specific, but frequently associated with asthma and smoking. Charcot-Leyden crystals. It'll be this orangophilic, rhomboid, needle-shaped crystals formed from the granules within degenerating eosinophils, and it's seen in allergic conditions like asthma. Ferruginous bodies. These are fiber particles, usually asbestos, encrusted with proteins containing iron salt. And it's important to mention given the possible mesothelioma risk. And it looks like dumbbells. Corpora amylaceae. These are spherical, concentrically laminated, non-calcified casts composed of glycoproteins. not specific. I mean, you can see these in benign prostate biopsies as well. And then you can see amyloid, which is this dense, amorphous, waxy material with classic apple green birefringence under polarized light with Congo red. You can have reactive epithelial change and from inflammation, and it can be really significant and can look really atypical sometimes. So always pull back, be conservative if there is a lot of inflammation. And for instance, instead of putting suspicious for malignancy, kind of backing off to atypical. Causes of inflammation include pneumonia, ARDS, infarction, bronchiectasis, abscess, intubation, radiation, chemotherapy, viral fungal infections, oxygen therapy. Your respiratory epithelium, as you can see here with the terminal bar and the cilia, they can be enlarged nuclei, they can have papillary architecture. They often retain your terminal bars and cilia. I mean, this nuclei is huge. I mean, you can fit 4 of these nuclei into this one, but you can see here they have this terminal bar and the cilia. Relatively uniform oval nuclei, a single nucleolus, abundant cytoplasm. Here you have this creola body, which are 3D clusters of bronchial epithelium with enlarged nuclei, vesicular chromatin, and smooth nuclear membrane. Basal or reserve cell hyperplasia, this is a mimic of small cell carcinoma because it often molds. And this is an abnormal multiplication of basal cells. And you can often see this with squamous metaplasia, and you'll have this cohesive sheets with uniform high NC ratio, just like small cell carcinoma. They'll have this even chromatin. They'll have small absent nucleolus, clean background, no mitoses, as opposed to small cell carcinoma with irregular contours, molding, lots of mitosis, necrosis. Another thing is small cell carcinoma is pretty large compared to your reserve cells. So reserve cells will be smaller than your bronchoepithelial cells, and small cell carcinoma will oftentimes be pretty large, will be much larger than your basal cell. Squamous metaplasia, you'll have this dense cytoplasm with some keratinization. They can have variable NC ratio, and they'll have round to slightly irregular nuclei, as you can see here. You can have type 2 pneumocyte hyperplasia, where you'll have large cells with cuboidal cytoplasm, large nuclei with prominent micronucleoli. Sometimes they can be vacuolated, and you can see viral inclusions sometimes. And then chemotherapy radiation changes. This is where it's important to get the patient's history, where with radiation chemotherapy changes, you'll have enlarged cells with big nuclei or cytomegaly, as you can see here compared to this nucleus. However, they'll have this maintained low NC ratio. You can see smudged hyperchromatic chromatin, and they can oftentimes have a vacuolated cytoplasm and can be multinucleated. All right, malignant, where you have unequivocal features of malignancy. When you say non-small cell carcinoma, you're thinking mainly adenocarcinoma, squamous cell carcinoma. If you're not sure, you can say non-small cell carcinoma, not otherwise specified. And this is used for FNA's biopsies without morphologic squamous or glandular morphology and indeterminate or negative IHC stains. And if a case requires stains to make a definitive diagnosis, you can say non-small cell carcinoma favor adenocarcinoma, or if you favor squamous cell carcinoma. Adenocarcinoma is the most common type of primary lung cancer, and they have this glandular differentiation. Cytologically, you'll see delicate, granular to vacuolated to foamy cytoplasm. They'll have frequent prominent nucleoli, and architecturally can be arranged in flat sheets, papillae, acini, and acini is nuclei at the periphery and cytoplasm in the center. And they oftentimes have this eccentric nucleus where it kind of extrudes outwards. You can see intracytoplasmic or extracellular mucin, and you can see a background necrosis, as well as coarse to fine chromatin, usually not hyperchromatic, and they do have nuclear membrane irregularities. And in well-differentiated adenocarcinoma, you can see intranuclear inclusions and grooves. IHC, your biggest one you want to use to confirm adenocarcinoma is TTF1, napsin A. And ours is TTF1 will stain nuclear positivity, and napsin A will stain cytoplasmic. And it will be negative for P40 and CK56. Note, mucinous adenocarcinoma may not express TTF1. And remember, TTF1 can also stain thyroid and also can stain liver, the cytoplasm of your hepatocytes as well. And distinction between adenocarcinoma in situ, minimally invasive, and invasive adenocarcinoma of the lung is not accurate on FNA and small biopsies. So here is an example of an intracytoplasmic mucin vacuole. Here is your architecture of acini and your mucinous adenocarcinoma. Squamous cell carcinoma is a malignant epithelial tumor with keratinization and or intercellular bridges. You'll have this keratinization, orangeophilia on PAP, and robin's egg blue on Gimza, or your Diffquick. You'll have this dense cytoplasm with well-defined cell borders. They have a central large hyperchromatic irregular nucleus, and usually no prominent nucleoli. It's polygonal, it can be elongated or bizarre shapes, and you can have keratin pearls, and you want to look for that dirty necrotic background, that tumor diathesis. Of note, basaloid squamous cell carcinoma has less specific morphology without keratinization. You'll have these clusters of high NC ratio cells with coarse chromatin, and this is difficult because it requires IHC to confirm your diagnosis and exclude small cell carcinoma. It is important to know you cannot distinguish primary lung squamous cell carcinoma from a metastatic squamous cell carcinoma from elsewhere unless the other primary is HPV positive and the lung tumor is squamous cell carcinoma is HPV negative, or potentially by molecular signature. So where we said your adenocarcinoma, your TTF1 napsin will be positive, squamous cell carcinoma, your P40, CK56 will be positive. Carcinoid tumor, this is a well-differentiated tumor with pure neuroendocrine differentiation. On cytology, you'll see small, loosely cohesive cells that can be epithelioid to plasmacytoid and sometimes spindled. If you look closer, especially on the PAP where you can see nuclear features better, you'll have this round oval nuclei with stippled salt and pepper chromatin. They'll have this dense granular cytoplasm, and it'll be a cellular smear, oftentimes with no necrosis. On your cell block, you can see nested and or trabecular architecture, and it should be positive for synaptophysin, chromogranin, CD56, and INSM1. Your Ki67 will oftentimes be low, less than 10%, but of note, it's not officially used for grading as compared to your neuroendocrine tumors of your GI origin. Unless you see necrosis or mitoses, it's challenging to distinguish between typical and atypical carcinoid tumors, because if you see necrosis, then that makes it bumps it up to an atypical carcinoid at least. So it is recommended to usually just report as carcinoid / well-differentiated neuroendocrine tumor, not otherwise specified, and defer final subtyping to a resection specimen. Small cell carcinoma. This is small cell size, usually smaller than 3 resting lymphocytes, but of note, just larger than your reserve cells. There's scant cytoplasm, unclear borders. You'll have this densely cellular sheet-like growth, and the cells are fusiform to round. You'll have this fine, granular, powdery chromatin, and there should be no nucleoli for the most part. You'll have high mitotic rate, greater than 10 mites per 2 millimeter squares, and you'll have frequent necrosis, often large zones and apoptosis. Sometimes you can see these paranuclear blue bodies as well, and you'll have frequent crush artifact, the Azzopardi effect, and that'll lead to chromatin smearing. Technically, this is a morphologic diagnosis, but IHC is useful to exclude other diagnoses like lymphoma, squamous cell carcinoma, like a basaloid, or sarcoma. And it's reassuring to have neuroendocrine marker staining, although up to 10% will be negative. IHC, it will be positive for your cytokeratins, AE1, AE3, synaptophysin, INSM1, CD56, TTF1, and it will be negative for P40, CK20, CD45. And Ki67 often essentially is 100%. And if it's lower than 60%, you want to consider another diagnosis. And remember, it can be combined with other tumors such as squamous cell carcinoma. And this is the most common neuroendocrine neoplasm in the lung. Your large cell neuroendocrine carcinoma will be difficult to diagnose by cytology, except if there's a good cell block, as you need to see the neuroendocrine architecture of nesting, palisading endorosettes. Cytologically, compared to small cell carcinoma, they'll be larger generally than your small cell, around 4 times the size of a lymphocyte. They'll often have more cytoplasm than your small cell carcinoma, and they'll have prominent nucleoli or multiple nucleoli. And on PAP, the salt and pepper is more like Himalayan salt and pepper. It's thicker. And here's a great table Dr. Schaberg provides in talking about the different characteristics of your typical carcinoid and atypical carcinoid, which are rare. Large cell neuroendocrine carcinoma, which is relatively rare, and your small cell carcinoma, which is your most often or your most frequent neuroendocrine neoplasm you'll encounter. Other malignancies, always mets, especially in the lung. Consider your history. Common sites include GI tract, breast, kidney, melanoma. Remember, melanoma is the mimicker of all things. Rare carcinomas that are hard to diagnose on FNA include your nut carcinoma, your thoracic SMARCA4 deficient undifferentiated tumor, your carcinosarcoma, your pulmonary blastoma, your adenosquamous carcinoma, your pleomorphic carcinoma. Lymphomas, where you'll have cellular smears of discohesive lymphocytes, lymphoglandular bodies, which are cytoplasmic fragments, such as like this, possibly these right here. It can be low grade, like your extranodal marginal zone lymphoma, which are CD5, CD10 negative, or high grade, like your DLBCL. And if you have enough specimen, you want to send it out for flow if you're unsure. Sarcomas, you can have your intimal sarcoma, leiomyosarcoma, as we can see here, your synovial sarcoma, your angiosarcoma, salivary gland carcinomas, which I find fascinating that you can have these in the lung. For salivary gland carcinomas, I find this fascinating that you can have these types in the lung. And it's thought, one of my staff told me that the submucosal glands that you see in the lungs, it's thought that these originate from them. But you can have your mucoepidermoid carcinoma, your adenoid cystic carcinoma, and epithelial myoepithelial carcinoma. You can have paraganglioma, mesothelioma, germ cell tumors as well. So Dr. Schaberg provides a great image of colon cancer mets. This kind of dirty necrosis. You'll have mucin. You have these glands of columnar cells with hyperchromatic pencillate nuclei, this kind of picket fence kind of look. Here's your lymphoma and your leiomyosarcoma. Atypical. This is a specimen with features predominantly seen in benign lesions and minimal features that raise the possibility of malignancy. And is often used in the setting of inflammation where there can be considerable reactive changes so that you don't overcall malignancy, and thereby maintaining a higher negative predictive value of benign. Suspicious is a specimen suggestive of malignancy but has insufficient features for a definitive diagnosis, either qualitatively or quantitatively. But it tells the clinician that you have a high degree of concern and risk of malignancy. And sometimes it's enough for the next step in management. Here is a great diagnostic algorithm that Dr. Schaberg provides, and this will be here just for your reference, and make sure to check it out. Again, adenocarcinoma, get your TTF1 napsin. If you're thinking squamous cell carcinoma, get your P40 plus or minus CK56. Of note, some primary lung adenocarcinomas, including mucinous adenocarcinoma, colloid carcinoma, and enteric adenocarcinoma, can be TTF1 negative. They can even stain with CK20 and CDX2, so that kind of bemuddles the picture if the patient has a history of colon cancer. So that's why these cases require careful clinical correlation to exclude a METS from the GI tract. So here's another table just for your reference. Thank you so much for tuning in to this episode of Pathagonia. This is Jay, and we really appreciate your support, and we'll catch you next time. Bye.